السلام عليكم. معاكم دكتور احمد محمد الجندي، استاذ الجراحه في كليه الطب جامعه اسكندريه، قسم جراحه الكبد والقنوات المراريه والبنكرياس. Today we'll discuss one of the surgical lectures that belong to the hepatopancreaticobiliary surgery unit. Our today lecture will focus upon the subject of liver tumors. The subject of liver tumors is very important, especially in Egypt, because we have a high prevalence for the malignant liver tumor, namely the hepatocellular carcinoma. Our lecture today will divide the liver tumors into benign and malignant liver tumors. From the benign aspects, we will focus on three tumors: the liver cell adenoma, the focal nodular hyperplasia, and the cavernous hemangioma. According to the cell of origin for the benign liver tumors, we can classify them as tumors arising from the hepatocytes, like the adenoma, focal nodular hyperplasia, and the cavernous hemangioma is originating from the vascular tissues of the liver. However, in the malignant liver tumors of the liver, we will discuss in details the hepatocellular carcinoma and the metastasis. We will begin by the benign liver tumors. The first liver tumor we will discuss for the benign is the cavernous hemangioma. The cavernous hemangioma is one of the commonest liver tumors. So it's one of the commonest liver tumor, around 20% of the benign liver tumors. It affects all ages, more common in females. It occurs equally in the right and the left lobe. For the hemangiomas that is exceeding 10 centimeter in diameter, we call them giant hemangioma. This is according to the size. They are considered as a type of congenital malformation. They have several drugs that has been postulated theoretically to affect the tumor growth, like some steroid therapy, estrogen therapy, and the hormonals of pregnancy. If you have a hemangioma, these drugs may accelerate the growth. However, the origin is mainly congenital. It is a congenital malformation, but these drugs may affect the growth. Considering the pathology, it's a vascular space. It's a vascular space lined by endothelium, as you can see here, together with dilated venous sinuses inside. It has a septa, and this septa is fibrous in tissue, and it contains blood, dilated venous sinuses, as you can see in here. The good thing about the hemangioma is that it's a benign condition, and most of them are found incidentally, and they are less than 5 centimeters, so they don't cause any harm. They remain stable over time, or they exert a minimal increase in growth. Most people usually discover them accidentally during the routine ultrasound. Rarely in the clinical presentation, they cause some pain when they are large in size, stretching the capsule. However, most hemangiomas remain asymptomatic. If they are large in size enough, they can cause compression of adjacent organ. Otherwise, they have no clinical manifestations. The problems with the hemangioma comes if you experience complications. We have 4 important complications that hemangioma can occur. One, it's called inflammation or inflammatory hemangioma, in which the patient will have an abdominal pain, will have an anemia, and have thrombocytosis. That's increase in the platelet counts. So this is called inflammatory hemangioma, and this should be treated by surgery. You remove the hemangioma, these conditions of the abdominal pain, anemia, and thrombocytosis will be relieved. The second important complication for the hemangioma is the alteration in coagulation. The alteration in coagulation, it makes the patient has thrombotic tendency. This is syndrome that, as described by the professor, called the Kasabach-Smerit syndrome, in which there is a alteration in the coagulation, there is intravascular coagulation, and you can find in it thrombocytopenia, decrease in the platelet. So in the inflammation, you can get an increase in the platelets due to the hemangioma, and in the second complication, the alteration in coagulation, you may get finally a thrombocytopenia, that's decrease in the platelets. So it's very important if you have a hemangioma patient to have a CBC in order to detect if this patient has an alteration in his platelet count, whether due to inflammation or due to alteration of coagulation. Also, if it's present, this is a second indication for surgery. You should remove this hemangioma. The third complication is hemorrhage. This is the most feared complication. However, it's very rare to have a spontaneous bleeding. Usually there is an inciting factor. The patient got hit or something like that caused bleeding. But hemorrhage by itself is very rare complication. And the fourth complication is compression for the adjacent tissues. Sometimes it causes compression of adjacent tissue. The diagnostic approach for the hemangioma, the diagnostic for them is ultrasound. The ultrasound usually detects the hemangiomas and diagnoses most of the hemangioma. This is the picture in the ultrasound. You get a rounded typical hemangioma that has well demarcated edges and the lesion is echoic. If you want to further detect or diagnose with accuracy the hemangioma, you have the dynamic imaging studies, the studies that uses the contrast. You have the CT and the MRI. You have the contrast going in the hemangioma and going out of the hemangioma in what's called the dynamic study. So the CT scan, you can see that in the hemangioma, you will have a peripheral filling of the dye. This is called peripheral enhancement, peripheral filling of the dye. Then in the venous spaces, in the venous phase, you will have complete filling of the hemangioma. This is a typical presentation in the CT scan. Because the hemangioma has the blood vessels compressed to the outside, you will have peripheral enhancement in the arterial phase. And because it is a venous space, you will have the dye entering in the venous phase. So this is the pre-contrast. This is the picture of hemangioma before injection of the dye. When I inject the dye, the white in color, you will have the white color in the periphery. This is arterial phase. Then in here, you will have the dye entering into the hemangioma in the venous phase. Complete enhancement in the venous phase. Typical pattern. Also the same in the MRI. The MRI is diagnostic and it have the similar pattern. You have peripheral enhancement in the arterial phase, complete enhancement in the venous phase. So you completely diagnose. You can see here the dye causing the enhancement in the venous phase. This is called the typical hemangioma. So when I diagnose hemangioma, what is the treatment? There is no treatment for asymptomatic hemangioma. If you accidentally discover hemangioma in the patient, you have to assure your patient. And if he is taking medications with hormonal treatment like oral contraceptive pills, he should avoid these drugs because they accelerate the growth of hemangioma. But you will not do surgery for hemangioma if it is asymptomatic. So when I do surgery for hemangioma, I will do surgery for hemangioma if it is symptomatic, causing severe symptoms, or if there are complications. What are the complications? The 4 complications we have mentioned: the inflammation, the alteration, coagulation, compression of adjacent tissue, and the compression, inflammation, and alteration of the coagulation. So if I have one of these complications, I will do the surgery. The surgery is a complete surgical resection. I will do hepatic resection, removal of this hemangioma. This is a classical picture. You have here a hemangioma affecting the right lobe of the liver as an example. Again, you can see here the hemangioma. Again, hemangioma, big hemangioma of the right lobe of the liver. This is an operative picture. You have this hemangioma in bluish or reddish in color. Again, this is the typical picture of hemangioma, and this is a liver resection for removal of symptomatic hemangioma. The hemangioma can reach a very big size, and by this it can affect and compress the adjacent tissues. By this we conclude the first benign lesion, and we will go to the second benign lesion we will discuss today. This is the focal nodular hyperplasia. The focal nodular hyperplasia, hemangioma, was the commonest. This is the second most common benign liver condition. It's more in females than in males, and usually discovered around the age of 30, 40 to 50 years. Actually, it's not a tumor. It's not a tumor. It's a hyperplastic condition. There is an aberrant blood vessel. that hyperperfuses a group of liver cells. So this group of liver cells will increase in size and form a nodular lesion because it has an excess blood supply. So the main problem is that I have an aberrant vessel that oversupplies nutrients to this group of liver cells. It will grow to form a nodular mass. So actually it's not a tumor. They are hepatocytes that are hyperplastic. They are increased in size. The typical presentation, if you bisect focal nodular hyperplasia, you will find what we call a central scar. This is present in 30 to 50% of the cases. You will find a central scar. What is a central scar? Central scar is this aberrant vessel. This is the aberrant vessel going in the nodular lesion and causing the hyperplasia of the liver tissue. So actually, this is the nodular hyperplasia, this is the central scar, and this central scar have the aberrant vessel. So usually these lesions are discovered accidentally. They are asymptomatic, they don't cause any symptoms. And as in the hemangioma, if they are large enough in size, they can cause abdominal pain, compression, manifestations of the adjacent tissue. Otherwise, they have no risk of malignancy at all. They have very low risk of complications. The complications like ruptures and bleeding are very rare. So you have a lesion that is not a tumor. This is a hyperplastic lesion that have very low risk of malignancy and very low risk of complications. The diagnosis is mainly also by the ultrasound, and you can see the central scar inside in 30% of the cases, but you have to confirm that with a Doppler. If you can see a central arteriole feeding vessel, this is a confirmation that this is a focal nodular hyperplasia. Again, the CT, the triphasic, the dynamic study, the dynamic CT and the dynamic MRI is diagnostic. You can see the hemangioma, the focal nodular hyperplasia. And because the focal nodular hyperplasia, it's a hepatocyte, it takes the dye in the arterial phase and washes out in the venous phase. So the CT scan and the MRI are diagnostic for the focal nodular hyperplasia, and you will see the enhancement of the hepatocyte in the arterial phase and the washout in the venous phase. So classically, this is the way of diagnosis. And if you are in doubt of the diagnosis, you can take a biopsy in order to assure the patient. Why? Because there is no treatment for the focal nodular hyperplasia if they are asymptomatic. They are not malignant lesions. They are not tumors. So if you diagnose the focal nodular hyperplasia, there is no treatment. You assure your patient only surgical resection is indicated if in doubt on diagnosis or if you have complications or the patient have symptoms. So again, this is the rule. You don't resect focal nodular hyperplasia if you are assured that this is a focal nodular hyperplasia because it has a low risk of complication. When should I resect the focal nodular hyperplasia? I will resect the focal nodular hyperplasia if there is a symptoms or if there are complications. This is a picture of focal nodular hyperplasia. This is a normal liver tissue. As you can see, this is an abnormal gross. This is the gallbladder. As you can see here, it is an exophytic gross, and you can clearly see this is a feeding vessel. If you accurately see, this is the feeding vessel. This is an abnormal vessel. The abnormal vessel hypersupplies this area, causing the hyperplasia, and this hyperplasia, as you can see, formed the nodular mass. So again, this is not a tumor. This is a hyperplastic liver tissue caused by the abnormal vessels. By this, we finish the second benign liver tumor, and we will shift to the important and the most dangerous benign liver tumor, the hepatocellular adenoma. The hepatocellular adenoma, it is a rare benign liver disease. It's not a common. So the commonest is the cavernous, second commonest is the focal nodular, and we have the hepatocellular adenoma. It is a rare benign liver condition. This one is strongly associated with the hormonal treatment like oral contraceptive pills and the androgen steroid therapy like the muscle builders. We take them at the gym. All these drugs, the hormonal treatment, the steroids, the anabolic steroids, and the oral contraceptive pills, estrogen progesterone treatment, all of them are associated with an increased risk of hepatocellular adenoma. However, also the hepatocellular adenoma can occur spontaneously without these drugs. However, this is rare. Sometimes they are solitary, but they tend to be multiple, so they can be multiple. They are a true benign liver tumor coming from the hepatocyte. They are a true adenomatous tissue. The small adenomas are asymptomatic. However, if they attain a large size, they cause compression manifestations or some discomfort and pain. Why they are dangerous? Because they have a tendency for complications. What are the complications? The most dangerous complication is spontaneous bleeding. This can occur in 20 to 40% of the cases, more in women and during pregnancy. So the hormones of pregnancy may induce bleeding in these adenomas. Also, what's dangerous is they have 10% malignant transformation. They have 10% malignant transformation when the adenoma exceeds 3 centimeters in diameter. So they are very alarming. There are two alarming complications. They were not present in the cavernous hemangioma. They were not present in the focal nodular hyperplasia. They have malignant potential in 10%, exceeding 3 centimeter adenoma, and they have spontaneous bleeding when it may be induced by pregnancy. So how can I diagnose? The same diagnostic approaches we followed in the focal nodular hyperplasia and the hemangioma. The ultrasound is one of the conditions that diagnosed, but I have to also resort to the dynamic CT and the dynamic MRI, and I can see in them the enhancement in the arterial phase because they are hepatocytes also, and the washout in the venous phase. The additive factor is that in the MRI I can see the fat and deposited in this adenoma, and I can see points of hemorrhage also inside this adenoma. So the diagnostic approaches in the radiology begins with the ultrasound and the dynamic imaging study with the contrast in the dynamic CT and the dynamic MRI. This is the picture of an MRI. As you can see, this is a hemangioma, points of deposits of fat and hemorrhagic spots inside the hemangioma, on the adenoma, I'm sorry. So this is a liver cell adenoma, large in size. This one also in the MRI. Again, this is adenoma and this is hemorrhage inside the adenoma, one of the most common and dangerous and feared complication of the adenoma. So the treatment here, it will differ. Why? Because they have a risk of complications. And in here, surgical resection is one of the main pillars, especially if the tumors exceed the 3 centimeter diameter size. So if I have a lesion adenoma less than 3 centimeter, maybe I can stop the treatment, I can stop the hormonal therapy the patient is given, and maybe I can follow them up because these drugs may accelerate the growth. If I can stop the treatment, maybe it will regress sometimes in size and became stable at like 2 centimeter or something like that. But the usual rule is that if the adenoma is above 3 centimeter, reaching 4 centimeter, surgical resection is indicated because the malignant transformation is there and the risk of bleeding is there. So if the diameter, the size of adenoma is very important factor in determining the indication for surgery. So in order to summarize, we will focus on 3 benigns: the cavernous hemangiomas, focal nodular, and the adenoma. Which one is the most common? The cavernous hemangioma. The most dangerous is the adenoma. By this, we finish the first part of our lecture. This is the part concerning the benign liver tumors, and then we will shift on the second part of our lecture, the malignant liver tumors. For malignant liver tumors, also we have, according to the cell of origin, the most common in Egypt. This is the hepatocellular carcinoma. The hepatocellular carcinoma is the most common in Egypt. However, in Western countries, the most common are the secondary or metastatic liver disease. So the secondary liver tumors is by far the commonest because the metastatic comes from every different organ in the body. The hepatocellular carcinoma, this is by far the most common primary. If it arises from the biliary epithelium, this is called cholangiocarcinoma. So the hepatocellular carcinoma, if arises from the hepatocyte, primary liver tumor. If it arises from biliary epithelium inside the liver, this is called cholangiocarcinoma. The hepatocellular carcinoma. The hepatocellular carcinoma is the most common primary malignant liver tumor. Occurs more common in males than in females. There is risk factors why the hepatocellular carcinoma occurs. The primary risk factor for the occurrence and the causative factor for the occurrence of the hepatocellular carcinoma is hepatitis B infection. Hepatitis B infection, this is an oncogenic virus. It's a DNA virus. It incorporates inside the hepatocytes and causes the hepatocyte to turn malignant. So the hepatitis B actually this is an oncogenic virus. It causes malignancy. This is in contrast to the second risk factor, the hepatitis C. The hepatitis C is not an oncogenic virus. It does not induce malignancy. However, it causes a change in the hepatocyte. It causes the hepatocyte to be cirrhotic. And then the cirrhotic cell will be transformed into malignant cells over like 15 to 20 years. So hepatitis B enters directly into the cell, making them an oncogenic virus, convert the cell into a malignant cell. However, the hepatitis C has a stage like C infection, followed by liver cirrhosis in like 10 years, then followed by malignancy in another 10 years. The most common cause of hepatocellular carcinoma in Egypt, the viral infection, the hepatitis C infection. However, in Western countries, the most common cause of the hepatocellular carcinoma is alcoholic intake, alcoholism. The alcoholic intake or alcoholism also induces cirrhosis like hepatitis C, and the cirrhosis will be converted to the hepatocellular carcinoma. So actually, we have a number of conditions that will cause the liver to be cirrhotic, and these conditions will end by, we'll have the liver ending in hepatocellular carcinoma, the cirrhosis ending in hepatocellular carcinoma. What are these causes? Biliary cirrhosis. If I enter into biliary cirrhosis, the cirrhosis also will convert to hepatocellular carcinoma. Sometimes some types of food toxins like aflatoxins. This is very common in Africa. The aflatoxin in food, in pesticides, in insecticides, when they are ingested, they will cause hepatocellular carcinoma. They are direct oncogenic effects. So the hepatocellular carcinoma clinically in Egypt, you will have a stage that this patient have a virus C, hepatitis C. Over time, he will become cirrhotic, and over time, the cirrhosis will convert to the hepatocellular carcinoma. So these patients should be followed up because you want to early detect the hepatocellular carcinoma. So we have a follow-up program on how to early detect the hepatocellular carcinoma if your patient have hepatitis C infection. How can I do that? I can do that by a lab test. This is a tumor marker called the alpha-fetoprotein. You should do the alpha-fetoprotein every 3 months, and you have a routine ultrasound check every 6 months. So any patient having hepatitis C or cirrhotic patient due to any other cause should be put on follow-up screening program for early detection of hepatocellular carcinoma. Lab test alpha-fetoprotein every 3 months, and you have an ultrasound every 6 months. This is a picture of an ultrasound. You can detect up to small lesions like 1 centimeter or more in the routine screening. So this is the criterion algorithm of early detection of HCC. You have to do an ultrasound. You can detect a lesion that is less than 1 centimeter or a lesion that is more than 1 centimeter. If you detect a lesion more than 1 centimeter, then you proceed to the second level of investigations, the dynamic studies, the dynamic CT and the dynamic MRI. So if the lesion is above 1 centimeter in the ultrasound, you have to go to the next level, the dynamic CT and the dynamic MRI. If you have the typical pattern of hepatocellular carcinoma, the typical pattern, enhancement in the arterial phase, the dye gets in, and then the dye gets out quickly, the wash out in the venous phase. This is the typical pattern of hepatocellular carcinoma. What do I mean by that? The normal hepatocytes get the dye inside during the arterial phase, and that gets the dye outside during the venous phase of contrast injection. But the malignant tissue makes this process much faster because it's hypervascular. It contains more blood vessels because they are malignant active tissues. So you have the enhancement in the arterial phase, but you have a rapid washout in the venous phase. This is very diagnostic. If you have the enhancement, the getting in the arterial phase, then rapidly in the venous phase it gets out in comparison to the normal hepatocyte, this is a hepatocellular carcinoma. So if you have this typical vascular pattern, this is enough. You don't proceed to biopsy. The CT is diagnostic. When you have the typical vascular pattern, what is the typical vascular pattern again? Enhancement in the arterial phase, rapid washout in the venous phase. So I have the typical vascular pattern. By radiology, I will diagnose the hepatocellular carcinoma, and then I will proceed to treatment. But if I have the over 1 centimeter lesion, but I don't have this typical vascular pattern, it's not very evident, I will resort to the biopsy. I will get the biopsy in order to confirm the diagnosis. So if I have a lesion in the ultrasound above 1 centimeter, I will go to the CT and the MRI. If I have the typical vascular pattern, I should treat. As in here, HCC, treat. If no typical vascular pattern, I will resort to the biopsy. So what about if I got a lesion that is less than 1 centimeter during the routine screening? If you get this, schedule your next ultrasound within 3 months. Don't wait for the 6 months interval period. Shorter time interval. Schedule the next ultrasound within 3 months. If you get a growing lesion, then proceed to the CT and MRI. If you have a stable lesion, no growing within 3 months, this is a cirrhotic nodule. This is not a early HCC. So if you have a stable disease in routine ultrasound, then this is a stable disease, and then go back to the routine follow-up. So this slide summarizes how can I early detect hepatocellular carcinoma in malignant, in cirrhotic patients. This is the CT I'm telling you about, the triphasic CT. This is before contrast injection. I cannot see any lesion. This is a hepatocyte and this is a malignant tissue, but there is no difference. When I inject the dye, as you can see here, I can see the tumor. It took the dye much faster, so the lesion is enhanced. The lesion is, this is the arterial phase, the lesion is enhanced. The lesion is white in color, it took the dye. So this is enhancement in the arterial phase. And then in the venous phase, what will happen? You can see the lesion in white, the white color disappeared quickly. The white color disappeared quickly. So this is called the washout in the venous phase. This is a typical pattern of hepatocellular carcinoma. Here is the hepatocellular carcinoma. Enhancement in the arterial phase and the word rapid washout in the venous phase. This is diagnostic and this is the typical vascular pattern. Again, this is a picture. This is the arterial phase. As you can see here, the dye, enhancement in the arterial phase, rapid washout in the venous phase. Rapid washout, they becomes much darker than the normal hepatocytes. If you compare the color inside the tumor to the color outside the tumor, the color inside the tumor to the color outside the tumor in the normal hepatocyte, you will have the color inside the tumor much darker. It washed the dye. The white color had faded away quickly in comparison to the hepatocyte. So you have an enhancement in the arterial phase, rapid washout in the venous phase. Typical vascular pattern. This is hepatocellular carcinoma. Treat, you don't need a biopsy. If you don't get this and you have a nodule, then you may resort to the biopsy. However, we have a certain pathological subtype. This is called fibrolamellar HCC. Fibrolamellar HCC, it can occur in top of non-cirrhotic patients. This type of hepatocellular carcinoma can occur in top of non-cirrhotic patient, and it is well encapsulated and can reach a very big size. And it does not cause the tumor markers to be elevated like the alpha-fetoprotein. You will have an alpha-fetoprotein that is normal, you will have no liver cirrhosis, and you will have a hepatocellular carcinoma. So this is a specific entity from the hepatocellular carcinoma called the fibrolamellar type. No alpha-fetoprotein in elevation, you will have no liver cirrhosis. So if I diagnose a hepatocellular carcinoma, I have to know what is the stage in order to choose the treatment. What we have is what we call a staging system called the Barcelona Clinic Liver Cancer. It was developed in Barcelona. They have staged the patients with hepatocellular carcinoma into what we call stage 0, stage A, stage B, stage C, stage D. What does this mean? It's somewhat complicated system. You don't have to memorize this, but you have to know that the treatment will be affected by two things. Will be affected by the liver condition of the patient, whether this patient is like child A or child B or child C, the liver status, and by the tumor burden, the number and the size of the tumor. So this patient has two diseases. He have the liver is diseased, so you may affect, you have deterioration in his liver function, and you have a tumor. So you have to balance these two and choose the modality of treatment that it is appropriate for your patient. So in order to summarize, instead of the complicated Barcelona Clinic liver cancer, we will divide the treatment options into two treatment options: curative treatment options and palliative treatment options. What do I mean by curative treatment options? Curative treatment option means that when I do this line of treatment, the patient will be tumor-free after that. The patient will be tumor-free after that. The palliative treatment options mean when I do this method of treatment, the patient will not be tumor-free. The burden of the tumor will be increased. Maybe I will have some control, but the tumor is not abolished. The tumor is always there, but in low quantity. So what are the curative options? They are the liver resection. I have resect and remove this tumor surgically. I have liver transplantation. I will do transplantation. I will remove the whole liver, and I will give the patient another new liver or lobe of the liver. And what we call a local ablative therapy, or the most famous are the radiofrequency ablation. And we will discuss these lines of treatment in detail. So the first options, I will have to discuss if there is curative options feasible for these patients. The curative options are the liver resection, liver transplantation, and the local ablative therapy. And they have their own indication. We will discuss in details. If there is no curative options that are available for this patient, I will shift to the palliative options. The palliative options, the first one is the transarterial chemoembolization or TACE. This is the first palliative option. I will have to discuss if there is no curative option available for the patient. So, in details, we will discuss first the curative options. What are the options that can be that your patient will be offered? The first, the liver resection. When shall I do liver resection for the patient? Number one, I have to have a child A patient, not a child B or child C. Child A patient. This is number one. Number two, I can, if it's feasible to do a complete resection, but I have to have a 1 centimeter safety margin. I have 1 centimeter safety margin, and I have adequate residual volume. So these are the three parameters that should be fulfilled. Number one, a child A patient. Number two, complete resection with at least 1 centimeter safety margin while leaving adequate residual liver tissue. This is the main indication of the liver resection. كده نص ساعة، احنا ده كده بقالي نص ساعة، فاضل نص ساعة. أنا أهو أنا برسل التايمر 32 دقيقة. عشان ما احنا ابتدينا متأخر عشان حكاية اللود. لكن أنا واخد ماسك تايمر عشان أعرف بس وقتي قد إيه.
كمل الحوار مش هقطعها.
أوكي. So this is for the liver resection. The liver resection, this is a surgical technique that is done in the operating theater with devices that are complicated. It will be done safely for the patient. The liver resection is the primary treatment option if the tumors are solitary in child A patient. See, this is the liver resection. The second option is the liver transplantation. What do I mean by liver transplantation? And why it is one of the best options for curative resections for hepatocellular carcinoma? This is because the liver tissue is cirrhotic and it has malignant nodules. It's cirrhotic and have malignant nodules. So there is potential that this patient will develop more nodules from the cirrhotic patient. So the best treatment option is I have removed all the liver containing the tumors and the cirrhotic nodules that have potential to develop further tumors in the future. So the liver transplantation, I will remove all the liver of this patient and I will give him in Egypt a right lobe because we don't have a whole liver, we don't have cadaveric transplantation. We have only living related transplantation. You will have a donor that will donate for the patient a right lobe. So for the adult, I will give him a lobe that is not cirrhotic liver, does not have hepatocellular carcinoma, and then this will be the best curative option for the hepatocellular carcinoma patient. But I have a certain criteria. Not all the patient can do this. What are the criteria? The criteria are the tumor burden. The tumor burden, the number and the size of the tumor. The hepatocellular carcinoma should be either solitary, not exceeding 5 centimeters, or if they are multiples, they should not be more than 3 lesions, none of them exceeding 3 centimeters. This is called the Milan criteria. So the Milan criteria governs the transplantations, the transplantation option. When can I transplant a hepatocellular carcinoma patient? I can transplant a hepatocellular carcinoma patient if he has a solitary lesion less than 5, or if he has multiple lesions, should be 3 lesions, none of them exceeding 3 centimeters. Provided that this patient does not have metastasis or does not have any vascular invasion of the tumor. So this is the main criteria for selection of transplantation. So liver transplantation is considered the first treatment option if you have a patient within the Milan criteria. Within the Milan criteria, the liver transplantation is the first treatment option. This is one of the treatment option of transplantation. This is a donor. You divide the liver of the donor into a right lobe and the left lobe. This is the right lobe and this is the left lobe. And then you get the right lobe of the patient, and then you remove the liver of the patient that has a cirrhosis and have the hepatocellular carcinoma, and then you re-implant. This is the cirrhotic patient that have malignancy, and then you prepare your right lobe of the adult, and then you implant it and put it in the place of the previously cirrhotic liver, and then connect the blood vessels and the bile ducts. This is called liver transplantation. This is one of the first and the best options to treat hepatocellular carcinoma patient if this patient is within the Milan criteria. The third option, the third curative option that is present after the surgical resection and the liver transplantation is the ablative therapy, and the most famous is the radiofrequency ablation. The radiofrequency ablation can be done to a child A and child B patient, provided that the lesion is less than 3 centimeters in diameter. This is very important. The best options and the best results for radiofrequency ablation is the hepatocellular carcinoma less than 3 centimeters. You will get marvelous results, maybe equal to the surgical resection, but inferior to the liver transplantation. But if the lesion is more than 3 centimeters, the results are not enough. The recurrence is much higher. So if I want to put in order the curative options, the liver transplantation comes first, followed by the surgical resection, followed by the radiofrequency ablation if the lesion is less than 3 centimeters. I should always focus the treatment option on these three options. If they are available, I will do them for the patient. However, the radiofrequency ablation is like delivering thermal heat through, to the tumor in order to induce the coagulative necrosis. So the local ablative therapy, radiofrequency ablation. So these are the three curative options. If they are available, they are the best. If they are not available, I will shift to the palliative option. What comes at the top of the palliative options is the transarterial chemoembolization or the TACE. Transarterial chemoembolization or the TACE. Transarterial chemoembolization, the patient should be child A patient with good renal function because the transarterial chemoembolization uses dye injection, and during dye injection it's excreted by the kidneys. So the transarterial chemoembolization, you deliver chemotherapeutic material and then you embolize and obstruct the feeding vessel to the tumor, and this will cause the tumor somewhat to regress, but this will not cause the tumor to die and does not recur again because the cirrhotic liver is still there. The transarterial chemoembolization, this is one of the commonly practiced procedure as a palliative procedure for the hepatocellular carcinoma. If the patient is more advanced than this and metastatic, then you will shift to the chemotherapeutic agent. The chemotherapeutic agent, one of the drug called the targeted therapy, this is sorafenib, given if the patient has a well preserved liver function in child A and he has metastasis. Then he will be shifted to chemotherapeutic agent like the sorafenib. So these are the options of treatment. If your patient is unfit for all of these curative options or palliative options, then you will shift it to only palliative. You will only for what we call symptomatic treatment. You will not give any treatment if the patient is far advanced than this. So you will always have to evaluate your patient for the curative options, the transplantation, the surgical resection, and radiofrequency ablation. If they are fit, you will choose one of these curative options. If not, I will shift to the palliative options. The TACE, the transarterial chemoembolization, or if metastatic, the patient will have the sorafenib or the targeted therapy. If he's not fit for this or that, then he will shift it to the symptomatic treatment. The counterpart for the hepatocellular carcinoma in pediatric age group, this is called hepatoblastoma, and this will be discussed in the pediatric unit. Also, the counterpart of the primary malignant liver tumors arising from the hepatocytes from the bile ducts. This is called the cholangiocarcinoma, and this will be discussed in the cases of the obstructive jaundice. By this, we conclude the one of the important part in the second part of our lecture. This is the primary liver tumor. And now we will shift to one of the important and the most common malignant liver tumor in Western countries. This is the metastatic liver tumor. By far, this is the commonest because they are metastases coming out from all the other organs. So what is the significance and why we discuss the metastasis in the liver for surgery? Because in some tumors, like in the colorectal secondaries, if you have a tumor in the colon and rectum sending metastasis to the liver, or the neuroendocrine tumors, or what we call the gastrointestinal stromal tumors, if these three types in specific sends metastasis to the liver, and the metastasis is only present in the liver, you don't like have a bone and lung or something like that, then this is indication for surgery. If you resect the liver lesions together with the primary colorectal or the primary neuroendocrine and the primary GES tumor, then you will have a curative options. This is not the same as in other metastatic disease, like in pancreatic cancer or breast cancer. But these three types of tumors, the colorectal, neuroendocrine, and GES tumors, when they send metastasis to the liver, this is an absolute indication for surgery. So when these patients are fit for surgery, they are fit for surgery when you can remove all the metastasis from the liver while leaving at least 30% of the liver volume. That's to say, I can remove up to 75% of the liver or 70% of the liver, and the residual liver of 25 to 30% can accommodate the life of the patient. So you never deny surgery for those patients. Always try to remove all the tumors with curative intent, with safety margin, while leaving residual liver tissue. This is the best thing you can do for these patients. Sometimes when the patient comes to you, he has far advanced tumor. He will receive chemotherapy, you will have some shrinkage of the tumor, and then you can resect the tumor. This is one of the example. If you have like a liver like this, you have multiple lesions in the liver. You have a lesion in here, you have a lesion in there. These lesions you will remove and pick and resect every part, maybe alone or together. So you always tend to resect the lesions of the tumors. You have to define them by radiology, doing the CT and the MRI. You have to locate the number, you have to locate the sites of the tumor, where the tumor is present, and then plan your resection. You have to know the relations of the vessels inside, and then put a plan for surgery in order to resect all of those lesions. As you can see in here, you have to remove the lesions. There is no limit for the number. There is no limit for the number, as long as you can remove all of them. As you can see here, this is a liver, this is a lesion in here, and another one in there after resection. This is the liver, the left lobe, and this is the right lobe of the liver. One of the underside, this is after resection. We removed a lesion from the left lobe in here, another one in the left lobe over there. This is one, and this is two lesions. We have three in there, four up here, five in the 5, 6, and then 7 and 8 lesion, 9 and 10. This contain 3 lesions after resection. So as you can see, you can pick your lesions, and you have to plan in order by the end you clear all the liver from the tumors. This is a colorectal liver mets. This is a colorectal liver mets. You have to plan to resect all the lesion of the liver. And then you put your drawing, you put your map in order to follow up this patient later on. Inside the operation, you have to use the ultrasound in order to detect the lesions, because the lesions sometimes, as you see, is very depth. The ultrasound is very helpful in order to detect the lesions inside the liver. So the intraoperative ultrasound is one of the useful tools. It's a mandatory tool when you are doing liver resections, especially for metastasis, to define the number of the lesions and to define the place you have to resect. You have to avoid the vessels and you have to clearly do resection with a clear safety margin. So never say never for a lesion of colorectal mets, as long as you can resect all the tumors with safety margin and there is adequate residual. These colorectal metastases can be done in the same setting like in a colon surgery, or they can be done later on if the tumor has been discovered later. When they are discovered at the same time, this is called synchronous resection, or if they are discovered later, this is called metachronous resection. So the hepatectomy or the liver resection for the colorectal liver mets, this is the main item for the line of treatment, and this is the only chance for cure of this patient. The same applies for the neuroendocrine liver metastasis, and the same applies for the GIST liver metastasis. There is no limit for the number as long as you can resect all the lesions with the safety margin. Of course, the line of treatment is not surgery alone. You have to continue the chemotherapy. Sometimes you need the oncologist to give you chemotherapy before the operation, and also you will have the chemotherapy after the operation. And by this, we conclude our lecture. Thank you very much.